Today, I want to explore one of the great contradictions in healthcare. We all agree that keeping patients healthy is the goal. Everyone supports the idea of prevention, early intervention, and managing chronic disease before it becomes a crisis. No one argues against it, and yet the system consistently underfunds it. That is the contradiction I want to unpack today. Because the problem is not that we do not believe in prevention. The problem is that the economics of prevention are far more difficult than the idea of prevention. Welcome to HealtheNomics podcast. Here we explore the forces shaping healthcare today and tomorrow. I'm Dr. Ayoub Ashraf, a healthcare strategist and consultant. So, in this episode, I want to do three things. First, explain what population health actually means and why it is more than a clinical idea. Second, why the money does not flow to it, even when the evidence supports the idea. And third, look at what is beginning to change. So, what is population health? The term population health is used loosely. So, let me be precise. Traditional healthcare focuses on the patient in front of you. Someone arrives with a problem, you treat the problem, and they leave. Population health asks a different question. It asks, what is happening to the entire group of people you are responsible for, including the ones who never walked through your door? That shift sounds small, but actually it is enormous because it means you are now accountable for the patient who did not come in, the one who missed the appointment, the one who could not get a ride, and also those who never knew they were actually sick. In the old model, that person was not your problem. While in this model, that person is exactly your problem. The county health rankings model, which was developed by the University of Wisconsin Population Health Department and Robert Wood Johnson Foundation, weights the modifiable factors that drive health outcomes. And in that model, clinical care accounts for about 20%, only 20%. The other 80% is social. Economic factors are around 40%, health behaviors are around 30%, and physical environment at around 10%. It doesn't mean that clinical care is unimportant. If you are having a heart attack, clinical care is 100% of what matters to you in that moment. What it means is that across a whole population, the variation in how long and how well people live, it is driven mostly by the things that happen outside the exam room: their home, their diet, their stress, their access to transportation, and whether they can afford their medications or not. So, population health is the discipline of managing health across all of that, and not just the medical episode, but also the condition around it. And what is exactly that makes it so hard to pay for? Because our payment system was built to pay for the episodes, a visit, a procedure, and a test. It was never built to pay for the slow, invisible work of keeping someone healthy. Now we talk about why the money does not flow to it. If prevention works and the evidence say it does, why is it so chronically underfunded? There are three reasons. And once you see them, the whole picture would make more sense. The first is the timing problem. Prevention pays off slowly. sometimes over years, and sometimes over decades. You invest today to avoid a heart attack that might have happened 15 years from now. But budgets do not work in 15-year cycle. They work in annual ones. So the cost is immediate and the benefit is distant. And distant benefits are very hard to fund, especially when the executive who makes the investment decision will almost certainly not be in the seat when the return arrives. The second is attribution problem. When prevention works, the saving is diffused. A patient who stays healthy simply does not show up. There is no bill, no event, and no clear line that says this is what we save. Think about how strange it is. Success in prevention looks exactly like nothing happened. And nothing happening is very difficult to put in the budget presentation. And often the organization that pays for prevention is not the one that collects the saving. An employer funds a wellness program, the employee later changes jobs, and the next insurer reaps the benefit. That is sometimes called the wrong pocket problem. The pocket that pays is not the pocket that profits. And when those are different, it becomes difficult to invest in such programs. Then the third is the volume problem. In a fee for service system, keeping a patient healthy means fewer visits, fewer procedures, and less billable events, which under that model means less revenue. So the system is literally paid more when people are sick. I want to be careful here. This is not a story about bad people. It is a story about the bad incentive. Well meaning organizations respond rationally to the way they are paid. As long as they are paid for the volume, the economics will quietly fight against the prevention. Now put those three things together and you see why this is so persistent. The benefit is delayed, the benefit is invisible, and the benefit often goes to someone else. And in the meantime, you are reducing your own revenue. That is not one obstacle, that is four, all pulling in the same direction. And then there is a fourth obstacle, which is the most underrated of all. When a hospital closes a service line, people are not happy. When a drug is denied, there is a story on the news, and then there is a named patient with a face. But the heart attack that never happened has no face. The person whose diabetes was caught early does not even know they were saved. They simply went on with their lives. So prevention has no constituency. It has no grateful patient telling their story and no advocacy group formed around the crisis that never arrived. And in any system where money follows attention, the thing nobody notices will always be the thing that gets impacted first. Now we talk if it is going to change or not. So is this a permanent flaw? Not entirely, in my opinion. There are three changes which are shifting the structure. The first is the shift towards risk-bearing models. When an organization becomes financially responsible for the total cost of care of a specific population, prevention stops being a cost and becomes a strategy. Keeping someone out of the hospital is not a lost revenue now. suddenly it becomes very important point in the healthcare strategy. This is the single most powerful force aligning money with the prevention because it solves the volume problem and the wrong pocket problem at the same time. If you own the total cost of the population, the saving lands in your pocket. The second is the growing recognition of the social needs. Health systems and payers have started investing in those areas that were never considered medically important. Housing support, food access, and transportation to appointments. And they're not doing it for charity. They are doing it because of the economics. Because it is often cheaper to address the cause than to repeatedly treat the consequence. Then, if you go back to that 20% figure, this is simply organizations following the evidence. If 80% of the outcomes sits outside the clinic, then eventually the money has to follow it there. The third is data and prediction. For the first time, organizations are investing more and more to identify who is likely to become seriously ill before it happens. And that changes the math completely. Because targeted prevention focused on the people who are the ideal candidates for intervention is far more affordable than prevention spread thin across everyone. This is the answer to the timing problem. You cannot shorten the payback period for prevention across a whole population, but you can find the people whose payback period is measured in months rather than decades. The picture is changing, but not that quickly. But the direction is clear. Here, I also want to be honest about the limits of all three of these because I think optimism here is often overstated. Risk bearing models only align prevention with money if the organization holds that population. It should be long enough to see that return. If the people change insurance every 2 to 3 years, the wrong pocket problems comes right back. But the investment in social needs remain very small as compared to what is spent on clinical care and is often impacted first if margins decrease. And prediction about the ideal patient is only as good as the data behind it and the willingness to act on what it says. So the direction is right, but the pace is slower than the conference presentation suggests. And the organizations that are genuinely ahead here are the ones being realistic about that, rather than the ones announcing it loudest. So let me return to the contradictions we started with. We all believe in keeping people healthy. The challenge was never that belief, it was economics, the timing, the attribution, and the incentive. Population health is not difficult because the medicine is unclear. It is difficult because the money has to be redesigned to support it. And that redesign is exactly what value based care risk models and population strategy are trying to achieve. The systems that solve this problem will not just be the healthier ones, they will be more sustainable. Because in the end, a system that profits from illness can never be as strong as one that profits from health. This has been HealtheNomics. I'm Dr. Ayoub Ashraf. If this was useful, follow the channel and I will see you in the next episode. Thank you so much.